As I told before, I'm talking about the molecular biology in multiple myeloma. So I apologize, my presentation is not on minimal residual disease, but I will talk about the molecular background and the genomic background of multiple myeloma. So multiple myeloma is a complex disease system whose dynamics over time is conditioned by several factors, which together contribute to the patient clinical course. Among different factors, therapy and genomic heterogeneity are very critical, and it is very important to understand the interaction between them to efficiently monitor the disease dynamics, thus preventing the disease recurrence and to maximize the efficacy of therapeutic approaches. The heterogeneity of multiple myeloma is expressed at different layers. There is an intratumor and intertumor heterogeneity. Moreover, a spatial and temporal heterogeneity have been described recently, and since different lesions might display peculiar genomic landscape within the same patients, and genomic lesions might change over time. Therefore, each patient with multiple myeloma is virtual and unique, and its diversity, even actually this evidence is commonly underestimated and not really taken into account in the clinical practice. Intertumor heterogeneity has been the first recognized, thanks to the conventional cytogenetics and FISH. Each patient with multiple myeloma carries several genomic aberrations, as shown here, and few of them are recurrent among patients. Today, it is well accepted that the multiple myeloma earliest genomic events are either translocation or hyperdiploidy, and that this aberration paved the way for building the myeloma clonal architecture with secondary abnormalities intervening progressively during the disease progression. The identification of pattern of genomic alteration might improve multiple myeloma risk stratification and prognostication and might allow to personalized treatment. To this aim, the identification of primary genomic aberration is critical. These are unique to a cell population with the same origin because they are non-overlapping, arise at the asymptomatic phase of the disease, and are detectable almost in the entire population of clonal cell within a clinical sample. Today, the introduction of high-resolution molecular approaches has highly improved knowledges on multiple myeloma genomics, and this is one of the lastly reported pictures of myeloma genomic landscape, showing that not only chromosomal aberrations are common in tumor cells, but also a multitude of point mutation and driver genes, among which several are recurrent, as shown here. Together with translocation and aneuploidies, which still remains the strongest determinants of the genomic substructure, the recurrence of 69 driver events identify several clusters of patients, as shown here, and 7 clusters of patients can be identified. For instance, here, we can clearly identify patients carrying odd number chromosomes hyperdiploides, and here is the cluster of patients carrying 414. The presence of different genomic aberration has been conventionally employed to identify subgroup of patients with different prognosis. For instance, here is shown one of the most recent stratification employed for clinical purposes, and here is a high-risk patients. As you can see, the main difference between this subgroup of patients is the duration of the progression-free survival. Another important level of heterogeneity is referred as intratumor heterogeneity, and describe the fact that each tumor includes a collection of related but different clones. This type of heterogeneity has been highlighted and is described by next generation sequencing, which has clearly demonstrated that the frequency of any possible single nucleotide variants that we can observe in a tumor clone might be less than 100%, that's suggesting that different population of cells might coexist within the same sample. In fact, it is now a common observation that most mutations described in multiple myeloma might be reported either as clonal or subclonal, a fact which also not only concern driver mutation, but also a mutation like those of the RAS pathway. This has an important implication. In fact, driver mutation might be invisible at diagnosis, but still present in small subclones. Intraclonal heterogeneity is the substrate for cancer evolution, disease progression, and relapse. In this context, the critical mechanism for tumor progression is competition between individual clones for the same microenvironment, combined with the process of adaptation and natural selection. This process might be very well described by the so-called clonal evolution theory, which applies knowledges of species evolution, ecology, and population genetics to understand how tumors respond to the selective pressure. This brings to the third important level of heterogeneity, that is the temporal heterogeneity. Myeloma, in fact, change over time, and the most clear evidence of this is that myeloma progression occurs throughout a multi-step process, which might start even decades before the first appearance of the clinical symptoms, a moment that conventionally distinguishes the clinical from the preclinical disease phases. Therefore, when we observe the genomic profile of a newly diagnosed patient, we should always remember that this might be the result of an evolution process starting year before the diagnosis, and that what we are looking might change over time. Last but not least, myeloma might change also in space. In fact, it has been recently demonstrated that also spatial heterogeneity is a common phenomenon in myeloma. This means that the tumor driver mutation and high-risk genomic aberration can be restricted to one focal lesion and be either absent or different at other location. Here, the underlying idea is that from the initial site of the tumor growth, tumor cells might disseminate through the peripheral circulation, following by a specific homing into bone marrow niche. In line with this, the fact that most patients present with multiple lesions at the time of a diagnosis might indicate that the process of cell dissemination or metastasis is activated in almost all cases of patients with multiple myeloma. The experimental evidence of this derives from a recent study whose rationale was that the single bone marrow samples would not be representative of the whole complexity of myeloma. In this study, a multi-regional CT-guided sampling has been performed in a cohort of 42 patients aimed at comparing the genomic profile of the different lesions present in a single patient. 73 patients has been analyzed by whole exome sequencing, showing that the genomic profile of the different lesion is actually different, as shown here. So why is so important to recognize myeloma heterogeneity and eventually study clonal dynamics? So far, tumors has been considered static and homogeneous targets. To this reason, treatment has been repeatedly delivered up to the exhaustion of drug efficacy. And disease dynamics have been monitored with a single sampling, which have been considered representative of the whole tumor. It is well accepted now that, on the contrary, tumors are dynamic and heterogeneous targets. As a consequence, therapeutic and monitoring strategies should adapt, and clonal evolution analysis should be guided therapeutic strategies. And this can be accomplished, for instance, by longitudinally monitoring the disease dynamics, analyzing not only tumor burden fluctuation, but also evaluating the qualitative changes that might occur within the clonal landscape. So to conclude, we can say that different layers of heterogeneity make every single multiple myeloma patient unique in its own diversity, that we should efficiently monitor the disease dynamics, and finally be able to tailor therapy according to patients' heterogeneity. Thank you for your attention.